Absolutely equal pressure on both sides.
It was pretty deep for 5 seconds each.
Yeah, that feels actually really nice.
She was not paid to say that.
I wish I was paid. I mean, this is enough payment. This is great already.
If you throw a restriction on one side, you continue equal pressure?
Yes, yes. I give equal pressure. It goes all the way down as far as it goes, and it's really when you release it that you get the springing effect. And it's a really easy thing to try and practice on anybody, and even without the rest of any of the stuff.
Wait, so are you saying this is therapeutic as well as diagnostic?
Oh yeah, it's only therapeutic. Well, I mean, I guess it is diagnostic because you're learning something, but no, it's meant to be therapeutic specifically. Yeah, it's correcting that as well.
And you don't know anything right now about what's going. He doesn't know what's going on with my body, but my back actually is out. Anyone that knows me knows it feels really bad right now, and what you're doing feels really good. So keep going.
You might want to start over.
Yeah. All right. So this is one of the things about manipulation that I always get a little like silly about. But you know, when we were taught, and again, we were taught by a chiropractor, no malice intended in that statement, but they're always hyper specific. Like you're putting this part of your hand on this joint exactly on this spot of this joint, right? Look at the size of my hand. Look at the size of Dr. Livingston, right? If I put my hand right here, how many of her lumbar segments am I contacting?
42.
All of
2 or
them.
3 probably, right? And I might have a patient that's even shorter. Now I might have a patient that's 7 feet tall and I'm really only getting one, but that's my point, is that being hyper-specific doesn't necessarily get us too far.
Are you central on that hand?
No, so it's the palm is just to the side of her spine.
So you're calling it the TPs?
Yep. And she's very, very tight here, so I'm not doing a lot of motion in the leg. Someone who was maybe a little looser or wasn't having this tightness in their back, you could go higher with this probably.
Oh, that feels so good.
What am I going to have to pay you?
I don't know. I think this is payment. Oh, yep.
Go ahead and turn over on your back, please.
Were you going straight down with that hand? The
No,
line
a
drive?
little bit superior.
A little bit superior, okay.
And again, because she's having a little bit of back pain and I could feel how sensitive she was, she kind of almost reacted when you get on there.
Tense
I
up,
wasn't
yeah.
putting very firm pressure. And another patient, can we turn the slides off?
Yeah, so it's not like any.
I'm like blind.
We don't want you to see us.
Barrier.
Yes.
We can do it anywhere. We can even do it blind.
I
So
About-
I would generally even do firmer pressure maybe than in some cases than what I was doing with her pressure. But
Thank you.
yeah, no problem. And again, this would be really great because I could lift the table up to me and I could do it right here and I wouldn't have to do what I'm about to do now, but that's okay. So we're just going to come down here somewhere. So in her case, I'm using the 3-finger grip. I'm getting several fingers at once.
I always talked about it as the three amigos.
There you go.
The pinkies you get too short and everybody becomes involved. It's the three amigos.
Yeah.
Are you doing traction?
A little bit.
Be careful, it'll set that paper on fire. Oh, well. As long as it doesn't set my computer on fire.
All of you watch me. I can't believe I haven't skipped this again. We don't know how many 3 seconds. All right, now for everybody's favorite part. I'm going to start from the left.
That's your right elbow.
So because it's so low, I didn't hit it properly. Here we are anyway. This is how it looks. Maybe you can see why when I was doing this a lot on a table this low, my back was killing me. I normally have my table up almost as high as it can go for this. Like I'm up here doing it. Which again, you can do it here, but yeah, sorry.
What will you do with your right hand?
This?
Yeah, when you
Stabilizing the shoulder.
Thank
Oh,
Because if you don't hold the shoulder down, you're just going to lift her right up, right?
How does that feel as a patient?
Really wonderful. I mean, later on, if you want to show them what you're doing, I don't mind
Okay.
you guys touching later when you're done.
Depends how many people want to do it. Although if you get time. Sorry again, I'm kind of breaking technique, but it's because it's so low, it's just how I have to do it. anybody wants to come in closer and see where my
And
hand's at.
I don't know if patients normally move their arm, this has never been done to me, but that just felt immediately like I wanted to do it on both sides.
Fine,
'Cause
I don't like people.
I think
And
gravity.
you
and
notice that
different-
his palm is, the fingers are on the top of her shoulder as opposed to down towards her chest. You want to kind of avoid that suggestion.
Yeah, that is a good point. I mean, also he has a better,
Thank you.
you're pushing better that way versus that.
Probably.
obviously.
The doctor who taught it to me would use his fists generally, but people seem to not like that as much. But it worked. Okay, so I lost my place. Are we on the abdomen now?
The PCT.
That was cranial.
Yeah, then you.
Sphincter. Sphincters now.
Sphincter, thank you. Now, also, I should say, all of the presupposes that we've already done a physical exam like processes, right? And so we're not worrying about doing a full physical on our abdomen. That's why I'm not checking on her liver or blood or something. We've already checked on that and ruled out any danger or problems. So just here for the treatment, we're doing. So we're gonna explore your abdomen.
Yep.
Fine there. What do you need to do? You need to bend your knees and your hips, just like this. So I just do it like this, so get the feet like flat on the table. I've seen it done with like bolster and that, but I think the more the better.
Yeah, okay.
For me.
You can, do you need more area?
I'll get to it. You okay with that? Okay, so we're just gonna check on that ileocecal valve first. Again, we're always using the pads of the fingers. We're never using the tips of our fingers. I think that probably goes without saying to all you, but just in case. So straight down on the ileocecal valve. No troubles. Straight down on the duodenal junction. No troubles. Straight down on, once he's done laughing, the sphincter of Oddi. Shock of all shocks, a naturopathic doctor has a digestive tract that just works fine. There's no problem. Nothing else to do. Let's pretend that her duodenal junction was a problem. So I'm going to treat it with the piezoform contact from my left hand. I'm going right down on top of it. It's easier to find when it's in spasm. And you're just going to kind of hold firm pressure right on it. It's uncomfortable for the patient. They don't love it.
It doesn't hurt, but it does, that feels
Yeah, it still doesn't
interesting.
feel good, yeah. And you're going to hold it for a few seconds until you feel it release. And I like to think of it as if you've ever pushed your finger through a thing of butter. Anybody done that? No, nobody has. Why would you do that? But that's what it feels like. It's when you suddenly get it.
If you have a kid who likes butter,
Hey, you never know. So those are the sphincters. So
only breastside.
I like to do that part first. The idea being kind of like, then if you need to move the stomach, now everything below it can kind of float
I see.
without issue. All right, so she's a great example, sorry, Kelly,
No, we're,
of
do whatever you need to do.
patient who has a kind of a very high angle to her ribs. So there's a lot of space between her xiphoid process and her umbilicus. And of course, everybody's a little different. You might have somebody where that's here, you know? So you have to palpate around the ribs and find out where you're actually at. So here's her xiphoid process way up here. I'm gonna come about an inch below that, half an inch somewhere there. I'm just gonna palpate that, see what I can feel. Yeah, is that done for you? No, yeah. Again, naturopathic doctor's digestion works, shocking, right? All right, but we're gonna pretend she has a hiatal hernia. Okay, so we're about an inch down. I'm not really gonna do it, don't worry.
No, you can.
Take a deep breath in. You kind of pull the skin up with it so that as you come down, breathe out, push down, and pull this way.
That's a J. Yeah.
Oh.
Yeah, it's a J, right? Who are these people that say
You can
C?
show them again.
One more time, Kelly. Deep breath in. You have to wait till they stop laughing, which is not usually a problem for me. Some people are very ticklish, though. And so they'll like giggle and tickle and like you can't do much until you get them to calm down. Okay, so she didn't have a hiatal hernia, but we did it anyway because we're wild people like that. So now we're just gonna empty your stomach. Kelly, you're just gonna breathe normally. Just, that's not how you normally breathe. So I'll do this. Fingers are kind of out here, and certainly you can flow them out to be more comfortable for the patient if you need to. And you see about how much pressure I'm using. It is half probably of what I did for the hiatal hernia, or would do. Or just
Is the pressure medial or dorsal?
pressure is dorsal, but then I'm drawing the fingers down.
Oh, that made.
See? Get a microphone in here.
So you're not sad anymore.
Gurgled.
Yeah, that's some good gurgles. Okay. All right. So we do that. So now I am going to step around the body. Sorry if I'm in your way. Now it's time to look at the colon here. So again, in this case, though, her ribs come way down and they're very close to the hip here, so there's not a ton of space for us to be grabbing the colon. This is so weird. Okay. so my fingers are grasping over the top of the colon, my thumbs are grasping around the back of it. So we're just gonna rock it in. And you don't even have a colon bowl for us to deal with.
Don't make it loud.
Bring us some problems next time.
I have plenty of problems.
Well, you know, Wendell did say give the psychological treatment along with it, right?
Psychological.
So in this case now we're moving over to the descending colon. So it's really just the reversal. My fingers now are wrapping around the back, my thumbs are around the front of it, and we're just kind of rocking it. I'm a little bit exaggerating it more than you really need to do so people can see, but it's just about this. And
And
again,
even though I don't have problems, it does actually even feel good without
sure.
an issue going on.
It's really especially great in a patient who's constipated, who's got that really full colon. You can feel every wrinkle of it. You can really get it.
Have you seen a lot of pediatrics with that? Or any at all, pediatrics with that? Or
Yeah.
that constipation?
Yeah, oh, yeah.
And like, is it, how effective?
100, yeah, very helpful. Yeah, I mean, I've even had pediatric patients with a hiatal hernia.
Yeah.
Yeah.
Are you just kind of rocking it like this, or are you rigging it?
Not ringing it, no. Yeah, I think that would probably hurt her.
Lightly.
Yeah, no, but yeah, just hands are together. Sorry, it moved. Yeah, so a little bit like that.
And you were saying that was
Not
an
like this, just
Yeah, yeah, it's very, very subtle, you know. Okay, so we're gonna look at the sigmoid colon. So we need to just come a little bit down lower here. And we're gonna tuck the thumbs in so we don't use those too much. We've got the pads of the fingers. And if Dr. Livingston were constipated, this would send her running, but she's gonna be okay. And it moves very well and easily, no troubles. So that's good.
What are your particular landmarks for locating the sigmoid?
So ASIS, really. So you start with that and you're just a little bit medial and kind of down there.
Okay.
And then I just bring my fingers straight down until I feel it. Down and kind of sweeping medially, maybe,
Okay.
I guess, yeah.
And what is the movement of that?
The movement of that is towards the umbilicus.
Okay.
Almost straight, but still with a little bit of that rocking.
Okay.
We're always doing the rocking on that stuff. Okay, so we finished her. What did we do so far, guys? We did the back, we did the kidneys, we did the head and neck, we did the abdomen. I think
remember the kidney.
That was the back.
that was when we bring the back leg
yeah.
down.
Back leg up, right.
So now,
For the abdominal stuff, any major like contraindications, like had they had like their gallbladder removed or like? they-
gallbladder removed, no. And in fact, those people are probably gonna need it more than anybody, you know?
But what if like they're like,
Like cholecystitis, yeah, that
Yeah.
was one of them.
Cholecystitis, yeah, is one of them. Again, like, use your clinical judgment. You might feel like this actually is a positive treatment in those situations, but you kind of better know what you're doing, I suppose. So I would treat them as contraindications until you were really, really good at it. Acute appendicitis, although again, frankly, right? But we live in a litigious society, so be careful. I mean, Lindor has a whole chapter on how to treat that. But there's a great idea, yeah. You know, gunshot wounds. Okay. All right, so thoracic spinal adjustments across her arms. We use that as a way to move her a little bit.
Does it feel good? Hold on, let me breathe.
You need to breathe.
I know,
It's
right?
not done palpating. Deep breath in. Breathe out. Again, what's the point of trying to be hyper specific about which joint?
like
you're
that
at?
lost
My
dog.
hand takes up 4 of her thoracic vertebrae. So there you go.
I miss school.
Turn on your side twist.
Yeah, that's all right. I know, right?
All right. So no, I'll take care of it. We're pretending you're a patient who doesn't mind.
I don't know that
There
one.
you go. So leg straight, bend the other leg. Twist her up like a pretzel here. Again, patient, listen to me, leg straight. So, anybody know what hyali is?
Yes.
Yeah, exactly. So if you've ever seen that, you have to Google it if you don't know. Think of your forearm as like those big scoops they used to throw the ball, right? So you're using your forearm to do this whole thing. So we're not going to contact any specific point. The forearm is going to contact basically perpendicular, if you can think of it that way, to the sacroiliac joint. And we're going to just pull the whole thing.
Oh, thank you.
And so her sacroiliac joint went, but I think there might have been a lumbar in there too.
Yeah.
You flip over on that side for us, please.
I mean, I don't know that. I'm not a doctor. She's not a real doctor.
Patients usually don't talk this much. Again,
I do.
the forearm is your scoop, perpendicular to the sacroiliac joint, roughly, if you can think of it that way. I don't know if that's 100% accurate. But.